The history of the health center movement is that when the leaders listen to the needs of the public, that's where they have the best outcomes. The idea of a community health center is that we're going to treat the whole family, the whole community, look at health holistically.
Over the 6 decades that health centers have been in existence, there have been many, many big political shifts.
They did vermin removal. They sprayed for insects. They killed rats. They killed snakes, because obviously all those things created health problems. But it was one of those eye-opening things, and of course all of those things were tied directly to poverty. COVID-19 is a great example of the disparities in health equity beyond can you get vaccinated, because there are all these other factors that dealt with morbidity and mortality.
Welcome to Community Health Centers Unfiltered, the podcast from advocates for community health, where we unpack the policies shaping community health centers and the patients they serve. Health centers are celebrating an important milestone, 60 years since the foundation of the modern community health center movement in the United States. While many people think of community health centers simply as clinics, the movement was born during the Civil Rights era and the War on Poverty, rooted in a much bigger idea. The communities themselves should have a voice in shaping the healthcare designed to serve them. Today, we're joined by Dr. Thomas Ward, Professor of History and Dean of the School of Arts and Sciences at Farmingdale State University, or College, SUNY. And he's also the author of a book, Out in the Rural, A Mississippi Health Center and Its War on Poverty. His research has explored the origins of the community health center movement and the social forces that shaped it. In this episode, we take a step back from the daily policy debates to explore how the movement began, why it has endured for 6 decades, and what its history can teach us about protecting one of the most important pillars of America's healthcare safety net. I'm really excited for this conversation, so let's get started. Hello, it's great to see you. Dr. Ward, can you do us a favor and just introduce yourself just to get us started?
Oh, thank you. It's great to be here. My name is Tom Ward. I'm a historian by training. I'm currently a dean at SUNY Farmingdale, which is on Long Island. But my field of study is healthcare history, in particular African American and Southern healthcare history. I wrote a book called Black Physicians in the Jim Crow South, and then another one called Out in the Rural, which is kind of the topic we're going to talk about today, which dealt with the beginnings of the community health center movement, specifically the Southern Center that was founded in Mississippi. And I'm currently finishing up a manuscript right now for Columbia University Press on the connections between the civil rights movement and healthcare.
I appreciate you. I'm first of all, I just want to start with that I'm very grateful for the work and the research and all of the time and energy you put into understanding and telling this story, because I think it's so incredibly important. And that is a great kind of start to our conversation, I think. And just, you've obviously spent so many years researching and writing about the origins of the health center movement. And obviously you've written the book. So I'd love for you to speak to, based on your research, when people hear the phrase community health center, a lot of times they think clinic. And what are they missing about the movement and what really was intended and accomplished when everything started in 1965?
Well, and it started kind of as a clinic, and what they found out is that a clinic was inadequate. The health center movement forms out of, broadly out of the civil rights movement. We can talk about that, I guess later, but directly out of a group of physicians and nurses, the Medical Committee for Human Rights, which was formed basically to treat the civil rights workers in Mississippi during Freedom Summer. During Freedom Summer, you have a situation where you have a number of doctors who are very concerned that as these students come to Mississippi and are going to engage in voting rights and other civil rights protests, that if they're beaten or harmed in any way, that local physicians won't care for them, black or white. And they were right. They were, most physicians wanted nothing to do with anything involved with the civil rights movement. So they come down, they do that in the summer of 1964. They treat these students, the activists, but what they find out is they're horrified by the health conditions that they see in Mississippi. And this isn't even by some Southern physicians, even by, we know one black Mississippi physician, Bob Smith, it horrified him. He was in Jackson and being up in the Delta and seeing how people were living in the Delta horrified him. And so when Freedom Summer was over, they kind of had a debrief, for lack of a better word, and they said, well, what can we do? It doesn't really seem to make a lot of sense for people to be marching for civil rights and voting rights when they're living in these horrible conditions. And so their initial plan is to start a clinic, and they do. They start a small clinic, the Millston Clinic, which is going to be run by Bob Smith, who was a member of the Medical Committee for Human Rights, and he was a physician in Jackson. And they hired Joe Disparty, who was a SNCC worker and a nurse, and they're gonna run this clinic 2 days a week, kind of on the edge of the Delta, north of Jackson. And they do that for a couple months, and they kind of have another debrief, and they say this isn't working. It's just not enough. The need is too great. Having a clinic is not enough. And so they say, well, we're going to write an OEO grant, and we're going to try to have what Jack Geiger, who's often considered the founder of the Community Health Center movement, Jack said is going to be a much more comprehensive program. He had studied in South Africa, had done basically a fellowship when he was in graduate school, and he had seen these community health clinics in African townships that focused on exactly what they say. They are focused on the health of the community, not just of an individual. When we think of a clinic, we're saying someone's sick, they come in, they get treated. The idea of a community health center is that we're going to treat the whole family, the whole community, and look at health holistically, and not just an individual problem. So I think that's the big issue. And looking at issues of nutrition, looking at issues of environment, looking at issues of housing, what we call today the social determinants of health.
Yeah, so we didn't have a chance to talk about this, Tom. So I was really fortunate to start working with health centers in 2005 and at NAC, and was really also very fortunate to work always in the policy and advocacy space, but with Dan Hawkins and under Tom and Mark Weatherhorn and many others, Craig Kennedy, many others who I think really embodied the movement, and then so many incredible health center leaders. But the story you just told, I remember being really struck when I first started with health centers that, hearing about Dr. Geiger's experience in South Africa, here we have 60 years later, this incredible program that, one has that rich history of success and accomplishment, and I think proof in what it looks like when you start to engage the community, when you empower, our local community boards and, empower consumers to really be leading what it looks like to craft the response and the operation to support the community. And like you said, all of the different social drivers. And I think the other thing that's really interesting is everything that's old is new again, because today we're talking about whole person care, we're talking about nutrition. And, that's another story I remember hearing really early on was that in the very early days of the health center movement and the health center program, a lot of times the prescription was just fruit and vegetables. It was groceries. And it's both affirming and heartbreaking a little bit to see the same need today, 60 years later, that, we certainly have made a lot of progress, and I'm so incredibly proud and inspired by the health center program, but I'm also, again, struck at the need that still exists today. But that brings me to the next question, which is just, again, I think when people hear community health center, they often think of the clinic. You address that, but I'd love for you to talk more about the movement. And I think, obviously it was connected to the war on poverty and it continued to evolve, but can you speak to that a little bit? Sort of like that word movement to me is very familiar because I've worked in the space as I have, but for somebody who's not particularly familiar, can you lean into that a little bit more and speak to what that's about?
Yeah, when I was working on the book, Jack Geiger was still alive. Jack interviewed me to work on the book. He wanted this book done. And when I was working on it, I would consult with him regularly. And he would always say, Tom, you got to remember, this is a civil rights book. It's a civil rights story. It's not just a health story. He was passionate about that. And he says it's very easy to say, well, this just comes out of the war of poverty. He says, no, it comes out of the civil rights movement. And if you look at almost all the leaders who were involved in the founding of the Community Health Center, they had all been participants in the movement. almost like I said, the Medical Committee for Human Rights is the organization that really founds the health center movement. And it's a situation where those were people, doctors and nurses, who had volunteered their time, but more than that, I mean, they in many regards put their bodies on the line, to take care of people. And we just had the anniversary of Selma, 2 days ago, right? And MCHR was there. I mean, Jack Geiger was there. Bob Smith was there. I mean, they were treating people that were beaten on the Edmund Pendish Bridge, and so it was the desire to get a handle on the gross inadequacies in healthcare was seen as part of the civil rights movement, and we don't always think of it that way. So Jack was very passionate about that. The war on poverty aspect of it, of course, was that was going to be the tool, right? There was now going to be this funding, and they could go to the federal government at a time when the federal government was funding these programs, and it's one of those things. It's miraculous how fast this comes, in today's world. The idea that they apply for this grant, and they not only get that grant, they get 5 times more money than they had wanted, because they were just going to do a kind of a demonstration and investigation, and the federal government says no, create two health centers, and so they do Columbia Point in Boston and Mound Bayou in Mississippi. And so, the war on poverty aspect is very important, but like I said, that's really the tool. The inspiration really is the movement that you had, these activists, physicians, and nurses that are coming out of the movement, and they see this greater need, and they want to pursue it. And truth be told, not everybody did. MCHR meets, in kind of this debrief, and a lot of them said, no, our job is done. We were here to, patch people up. And others are saying we can't walk away from this. We'd be. This is part of the movement, and we have to kind of continue with this. And so it is very much intertwined. I don't think you could have one without the other.
Yeah, I agree. And I feel like, we'll get into it maybe later, but it's interesting because when I started in 2005, that the heart, the movement part of it was still very, very present. And it was still a lot of the same people who, literally when everything started, were putting, painting walls and putting up wallpaper and, just trying to make it work and cobbling together whatever they could with grant dollars and, in the basement of the church or whatever it was. And so that movement piece is still, I think, very much alive today, but it has changed a bit. We'll get into that. But the other thing I wanted to talk with you about that I think, again, I'm really grateful to those that I learned under when I started, but I think it's such an important part of what differentiates health centers and really at the core of, I think, both the movement, but also just everything that is health centers. That's the Consumer Majority Board. But I'd love for you to speak to why is that so different, and how was that so novel at the time that it started? But I think even, thinking through history, and obviously you've done research across lots of different spaces. So I'd love for you to speak to that a little bit.
Yeah, the boards started out as what were called health associations. And the very first one was at the very first health center, Columbia Point in Boston. And a big part of it, Columbia Point was a large housing project. And the idea was that the people there needed to have a seat at the table and to help make decisions about their own health care. Now, part of this went to the OEO's maximum feasible participation of the poor. So if you're getting OEO money, you had to include the people who are going to benefit from those programs. But Jack Geiger and Count Gibson saw it greater than that you needed to have people there because they could see the problems that you couldn't. In Columbia Point, one of the examples is travel, right? You think of, well, you're in Boston, you got some of the greatest hospitals in the world. I mean, they're right there. But if you're in Columbia Point, you had to get on like 3 or 4 buses. It's an all-day event to get to a place. In Mississippi, John Hatch, who is the community organizer, John goes down early, and he kind of is trying to get community participation before there's even a health center, because he wants to have the community on his side. And he develops the health association before there is a health center in Mound Bayou. And part of that was to find out what they needed. And I think this is really instructive, and probably, I was talking at an event a couple months ago and say, it's very instructive for, health center leaders today, because Jack Geiger had done a lot of research on Mississippi, had been in Mississippi, and he had planned that the health center was going to deal with maternal and infant care, because the maternal and infant, death and mortality rates were astronomical. And they were horrible. But when John Hatch was, working with people, that's not what they were talking about. They were talking about food. They were talking about jobs. They were talking, one of the things he found is there was a tremendous amount of need for elder care, because much of the Mississippi Delta had kind of been hollowed out because young people had left to go to Chicago to try to make money, Chicago, Detroit. And so you had a lot of people left behind. So what Jack and the other planners of the Mound Bayou program thought they were going to deal with and thought they needed to deal with and focus on was not necessarily what the community needed. And so to get that feedback on what they needed was really important. And I think, like I said, I think Jack learned that in Mound Bayou even before he got there, because John Hatch had done such a job in working with the community. And his job was really to make sure people were on board. But what he found out is not only was he trying to get them on board, but to figure out exactly what their needs were, not what.
I'd love for you to speak to a little bit more, just in terms of your research on the Delta Health Center. Mm-hmm. What did the early experiment reveal about the connection between healthcare, poverty, and community power? And you spoke to this a little bit, but just going to go in a little deeper.
Yeah, and I think it was so central to, gets back to what they find out. Jack knew that Mound Bayou was impoverished. He knew the Delta was impoverished. He knew he was going to have to deal with certain issues. But when he got there, things were both so much worse than he thought and also different than what he thought. Like I mentioned, the maternal and child care was what thought he was going to focus on. But, as John Hatch walked around, he said, people would say, well, healthcare sounds good. And you mentioned this, but what we really need is food. Yeah. And one of the controversial programs that Geiger, put forth is he put in a food prescription program soon after he got there, where he worked with local grocery stores, and they paid for milk and eggs and other foods out of the pharmacy budget. And when the OEO found out about it, they were really pissed off because they say you can't, the prescriptions are for drugs, right? And you can't buy food out of your prescription budget. And Geiger said these people are malnourished, and the prescription for malnourishment is food, which of course is both simple and kind of horrifying in some regards when we think about it. And so because of that, they then put in a food budget. So one of the things that they found very early on is the problems were both so bad and so basic at the same time. Yep. that you got to provide people food. Clean water was another one. They would send people home with prescriptions, and some of which had to be mixed with water, and people are getting sick, and they go by their water. They didn't have clean water. Many of the people that they were treating either got their water out of ditches at rainwater, and they took it out, or they had 55-gallon drums that were on the plantations that they would take into town and fill up with clean water. But those drums had originally been used for pesticides. So you're keeping your clean water, your water supply in these 55-gallon drums that had originally had pesticides in them. So, this created a situation, once again, something that they had not intended. But then, a big program was, well, we're going to put in pumps. They're going to have, pump drilling. And they put in, Jack used to say, you drive through Bolivar County, you'd see all these little orange-handled pumps. He said, we did all those just to get people clean water, because you couldn't have health if you didn't have clean water. There wasn't sewage. Most of these houses were unplumbed and sewage. They had sunshine privies, open privies. which created problems once again with your drinking water, created problems with attracting bugs and other vermin. And so, one of the programs they did was they built sanitary privies. Now, this is the late 1960s, and even the chief sanitarian, Andy James, said this was not ideal. He goes, I don't want to be building privies in the late 1960s. He says, but we had to deal with what we had to deal with, and having a sanitary privy was better than what people had, which was basically just this, the human waste and, flowing in their backyard. And so those are the kind of things where, like I said, things were so simplistic and so, so basic to human health that most of the country didn't even think of those issues. But to say, okay, we've got to have better food, we've got to have clean water, we've got to have sewage. Some things as basic as, one of the things that they saw early on was all these children were coming in with burns, and they couldn't figure out why all these young children were coming in with burns. Well, a lot of the shacks were heated only by a stove that was in the middle, often also made out of these 55-gallon drums. You kind of create, and it was hot. You put wood in there, you heat the house that way, but a small child would bump into it. So they created programs where they just created little fences in the house to keep kids from running into those. Well, you're going to protect people that way. They did vermin removal. They sprayed for insects. They killed rats. They killed snakes, because obviously all those things created health problems. But it was one of those eye-opening things, and of course all of those things were tied directly to poverty.
Yeah, again, it's hard. It's hard to imagine that, to your point, like we're not talking the turn of the century. We're talking late 60s.
Yes.
And that was the reality. But I have to be honest with you, there are still health centers. I speak with CEOs, with some regularity, where they still have patients, they still have families who don't have electricity, who don't have running water, who, we've come a long way, and I'm grateful, and I'm, proud of that. But there's still, I think your comment about the majority of the country doesn't think about that. It's unfathomable to think, someone doesn't have running water, or, doesn't have consistent electricity, and that's reality still for a segment of our population even today.
Or clean water. I mean, Jackson,
Yes.
Mississippi, Flint, Michigan. I was thinking of Flint, Michigan, Baltimore. I mean, I have friends that teach in Baltimore city schools where some schools you can't drink the water. So these a lot of Native American reservations you can't drink the water.
Yep.
There's still sewage issues in parts of the Deep South that cause health issues, where the infrastructure has been allowed to go away and not be repaired.
Yeah, it's interesting. I don't know if you're working on another book right now, Tom, but we had AC Locklear from the tribal community with us for a conversation just recently. And my goodness, I mean, so many of the challenges that he spoke to are very much consistent in the health center community and sort of the populations that we serve. But talk about, might be another, if you haven't thought about the next thing you'll be writing on, it may be worth looking into that and connecting with AC. But a few more questions for you. I mean, so one of the phrases that came up a lot and that was really relevant throughout the process is maximum feasible participation. And that was a big part of early policy. Can you just speak to what that looks like in practice inside the communities?
Yeah, I mean, I think part of the things we've just been talking about is that the community can say these are the issues we want taken care of. That yes, it's one thing for the doctors, either they coming from New York or even coming from the local areas, to be bringing kind of top-down care. The health associations and the boards now, that's kind of the bottom-up needs. And they say these are the things we need. As we were talking about, be it clean water or food or even jobs. And in the early health associations, they also found that they often found very specific needs that maybe only their health association did. Like I said, in Mound Bayou, you have the health center in Mound Bayou, but all the little communities form their own health association. So they all dealt with kind of health issues, and they reported back to Mount Bayou and what they wanted. But they also would create some of their own things. So, some might have child care, some might have elder care, some might have legal aid. Almost all of them, had at least some type of community center, even if it was just an outdoor area that they would have a barbecue once a month or something. Some had clothing drives, right? And so what the maximum feasible participation and really emphasizing that early on was saying it was empowering the community to say the health center's got to be responsive to your needs, instead of it being a top-down program of someone coming from outside, or once again even inside, because a physician almost by very nature is going to be of a different class, right, of a lot of the people they're going to be dealing with, and not always see the same needs, and say this is what we want our community. These are the services we want our community to have.
Yeah, it's interesting. This is something that I speak to a lot and have over the years, especially when speaking with policymakers, because there's really something special about health centers in as much as it's completely nonpartisan and apolitical. But I think from an ideologic perspective, it touches the entire range. But I think for that piece in particular, I think the value of what you're speaking to, which is, no offense to all of the incredible professionals in Washington, D.C. and policymakers, but it's really difficult for somebody sitting behind a desk in Washington, D.C., even when they have a mountain of data and all of the research and everything else with good intentions, to know what the needs are in rural West Virginia, or frontier Alaska. It's a completely different scenario. And so that is one thing that I'm so grateful for, that part of our model, because as you said, who better than the people on the ground to be able to say, no, this is actually the need. And I think in today's reality, some of the things that we've been talking about, unfortunately, continue to span and be a need today. But I think how incredible and wonderful to see the continued success of the health center program in being able to respond to needs, whether it be substance use disorder, mental and behavioral health. You mentioned childcare. I think, being responsive to cultural needs, if there is a community that has a specific way that they need to receive care, or a specific lens in terms of how they receive it, that part of the model, I think, is so vitally important. But also, again, I think that's a differentiator. And it's really interesting as I've, done this work and, like I said, spoken with policymakers, because I watch them sort of have this light bulb moment where whatever perspective they're coming at it from, there's typically something that resonates where they say, oh, okay, so my community is actually the one determining, out beyond the basic framework of you have to do this in order to be qualified. They then have the opportunity to say, no, this is the actual need in the community. We don't have a safe space for physical activity. We need to do better with, access to fruit and vegetables. We need a garden space, whatever it is. Yes. And I think that's the beauty of health centers. That's the beauty of the program. But it's also a nice segue to my next question, which is, you've obviously done your research. You've been working on this for decades. But over the 6 decades that health centers have been in existence, there have been many, many big political shifts. And so why do you think this model endured? And particularly when we think about, many others, frankly, who came through came out of the war on poverty, that didn't necessarily continue to succeed. So what do you, through those political shifts, what do you think is one of the reasons why health centers have continued to receive support and succeed?
Well, I think there's two parts to this answer. I think the basic answer is they've succeeded and lasted so long because they've worked, right? They've worked. They've brought care at a very good price, if we want to look at it from an economic point of view, from the federal government in the support. But they also, to get to your earlier point, they exist kind of in very different places. They exist everywhere. They exist in all congressional districts. And like you said, the need in rural Mississippi may be very different from the need in the Bronx, but the need is there. I mean, what is the community health center is providing in one urban area in the Northeast is different from what's providing in the rural South or in the West, or you mentioned Alaska, but they're filling that need. Right, mm-hmm. They're filling that need. So I think in one case you say, well, they've survived this long because they're filling the need. They're doing it in an economically viable way. They've worked. But the other side is that they have faced pressure. I mean, the health centers have not always been universally supported. They have had challenges going back to their founding. I mean, there was tremendous opposition, especially in the South, to having anything that smacked first of the federal government and second of the civil rights movement, or maybe vice versa. When you had these activist physicians coming in and doing something, to the point where the state of Mississippi is saying, no one is denied health care here. Everyone's got great health care. This is totally unnecessary. But then, during the 1970s, both President Nixon and President Ford vetoed spending for health centers. Now, those vetoes were overridden in part because they were so supportive by so many people. But the fact that there was opposition from the presidency, and you do have, even though the vetoes were opposition, you do have a lot of the programs cut. And I know Jack Geiger used to talk about the problems with the 70s and the 80s is that we had to go to what he called a leaner and meaner model. And to go back to our kind of very first question, they became more like clinics. They had to drop a lot of the innovative programs that they had been that had characterized the health centers of the 1960s, and they became more like clinics, just treating ailments, providing vaccinations, things like that, not really doing as much as we really think of it as community health. In the 1980s, there were over 180 health centers that were either closed or consolidated because of budget cuts. So you did have that opposition there. Even in the 2010s, with the failure of many states, especially states in the South, refusal to expand Medicaid, that affected a lot of the health centers. Mississippi was the only state in the union that actually saw the number of uninsured people grow after the passage of Obamacare, which is almost, it's amazing. So, yes, the health centers have weathered all these storms, but they have had to deal with a lot of storms. But I do think, it comes back to the original part, is because they are tuned to their local community, there's usually so much local support that especially, congressmen and women, stand up for them across party lines.
Yeah, I was going to say, and that, one of the other things I was going to ask you about is, the reason for the bipartisan support, which is historic. It's always been that way.
Mm-hmm. Yes.
I think as a function of, all health centers are 501c3s. They are nonpartisan. They are, completely removed from politics. But again, I think to what I mentioned earlier, I also think if you think about the political rainbow, there's something that appeals to all elements of what that looks like, whether you are, the most progressive of them all and you want, health care for all, where you have health centers, or you are the most conservative or libertarian even, and you look at the consumer majority board, you look at the fact that many of them are, essentially they are small businesses and or in rural, it depends on the community, just like anything else, but, they're really important economic engines in their community. Like, there's just so many different things, I think, that account for the really, really strong and persistent bipartisan support.
I think that's an important point you say about them being an economic engine. This goes back to the 1960s that they employed people in the community. I mean, they're not just cost neutral. I mean, they are economic benefits to their community. And like I said, the local representatives know that. You may have a a president or a governor who may not see that, but local representatives know that to take funding away from the health centers is to hurt the economy of that area. Just like when, if you close down a military base, no one ever wants a military base closing down because they're economic engines. And the community health centers have been economic engines of their communities since they were founded in the late 60s. And so I think that's another reason why there's been bipartisan support.
Yeah, I totally agree. And I think especially at the moment, but I think always, there is this even split rural to urban. But I think, when we think about that particular scenario in rural communities where sometimes the health center is the largest employer,
Yes.
and if, to your point, if those doors shutter, it's bigger than just losing access to care and the impact that has, even from a cost perspective on, okay, you're not managing chronic illness and people are, where else are they going to go? They're going to prolong care or forego care or end up in the emergency room, which is, problematic and costly. But I think it's all of the people that are employed. It's all of the goods and services that the health center is taking on in order to operate. It's a hugely important part of the ethos of the community. And I appreciate you calling that out too, because, we have many health center CEOs who talk about that a lot, that it's not just that they have their consumer majority board and they're responding to the needs of the community on the basis of that. Their entire team is from the community as well.
Yes.
They are also helping to inform and respond to the needs of the community because they themselves are living it. So I obviously I'm biased having done all this work for as long as I have, but it's really beautiful. And I don't know I really, talking with AC, again, sort of speaking to the tribal community, was probably the closest thing I heard of really similar. I was like, oh my goodness, this sounds a lot, like health centers, but I haven't found it anywhere else. I really haven't, which, I'm proud of in a way, although I think others could learn a lot from the health center model, if you will. One question for you, Tom, and you did speak to this a little bit, but in the history of the 60 years, there certainly have been some battles and some ups and downs, but I think sometimes in this moment where there is a lot of change and a lot of challenge, it's easy to forget that there have been really significant existential threats that have come to health centers in the past. So from a historian's perspective, can you speak to that a little bit about maybe one or two that really stood to completely disassemble the health center program?
Yeah, I mean, I think, like I said, you can go back to even the very beginning, where while there was this OEO funding, but a lot of the states didn't want it, especially the deep South states. Mississippi, it was a huge fight that Geiger had to wage to try to get support. In fact, one of the things that he had done purposefully was have Tufts University sponsor, because the OEO as part of the funding. When the law was written, it gave governors veto power over OEO programs in their states, and Southern governors had demanded this. The only place they'd have veto powers if it was something through a university, and of course the governors acceded to this or really didn't think about it because they always assumed it would be universities in their state which they had control over. So by having Tufts University in Massachusetts sponsor a Mississippi program, Jack made it veto-proof by the governor, and it also would not have survived. I mean, they would have killed. They tried to kill it. They tried to kill it anyway. And some of the other early conflicts also had to do with, and this happened in a lot of we talk about war on poverty programs. What happened to a lot of war on poverty programs was that. There was corruption, or there was such a desire that all this federal money's coming in, and locals wanted to control it. So Jack had a lot of fights with local leaders, black and white, over who was going to control the funding. And of course that was what ruined a lot of OEO programs was the waste that was created because people were fighting over this money and who's going to get to spend it. So I think there were real problems early. The block grants under President Reagan was probably the next real crisis. Like I said, there were crises in the 1970s. There were cuts. but the program, there were so many programs that were either cut or consolidated in the 1980s. So the number of health centers physically shrunk, even though as kind of the people they served kind of continued to grow. The actual centers shrunk. And then I do think, Obamacare was actually great for the health centers. It injected a lot of money, but the failure to expand Medicaid in a lot of places really created problems and continues to create problems in the poorest states and in the poorest areas. So, which of course puts, in some regards, more pressure on health centers to do more with less in those areas.
Yeah, I think the do more with less
Yeah.
has been an unfortunate expectation and reality for health centers for quite a few years at this point, which is really hard. And obviously, like I said, we're in a time of change and challenge. But I also, you spoke to innovation earlier, and it's really interesting because my tenure with health centers is short by comparison to many, but I've always thought of them as really innovative, particularly when I look across the healthcare system as a whole. But I hear what you're saying in terms of when things began, there was even greater flexibility to design it, with social determinants in mind or social drivers in mind. But I have to say, it takes creativity. I think particularly, HRSA has done a really wonderful job, and I'll shout out Jim McCrae and his team, and but the current administrator and administrators past. HRSA has done a really great job of trying to support and empower health centers to be innovative and creative, to respond to the needs of their community as much as they can within the the guidelines of rules and regulations, policies, etc. But I also really credit health centers because they are masterful at finding a way. Even if the resources or the policies don't exist or lend themselves yet to addressing the true needs of the community, they find a way, and sometimes that's finding unusual partners or, getting creative with how they bring in dollars to support, whatever the expansion must be. But we are really fortunate at ACH. We have some of the most innovative health centers in the country as a part of our network. But I also think that's just part of the health center story. And I think that's it's somewhat by necessity because they are so committed to mission, and part of that mission being to respond to community needs, whatever it looks like, and again, you can hear my passion and my biased appreciation for health centers. It will always be that way. So a few more questions for you. I'm looking at the time. I know we're getting short, but so one of the things I wanted to ask you about is health equity. I think when we talk about health equity today, it means maybe something different. But my question for you is, do you think in the context of that we're rediscovering principles that were embedded in the model from the beginning?
I think there is a rediscovery. I mean, and I was thinking when you were talking about how a lot of the health centers today are trying to be creative with what they have. I mean, I know I've talked to people say, well, we've created a community garden, which is great. I mean, that's wonderful. But that's kind of going back to what they did in the 60s. I mean, Mound Bayou had a farm co-op, as Elsie Dorsey said, we got the richest land and the poorest people. Let's do something with it. And so kind of rediscovering ways to meet needs because so many of those needs go beyond, getting your vaccinations or getting your well baby checkups. It's living in a food desert and finding a way to get good food. Aaron Shirley, who was one of the founders of the Tufts Delta Health Center, he talked about in the early 2000s. He said in the 1960s, people in Mississippi were dying of malnutrition. Now they're dying of bad food. He said, I see all this obesity from the only thing they get is processed food, and the only thing they get, soda pop and things like that. And that could be, in any, disadvantaged community. It wasn't just Mississippi. And so, sometimes the demands change, but sometimes they're intertwined. So, having good food, as we kind of talked about a little bit earlier, a part of health equity is having clean water. part of health equity is looking at other environmental factors. We know that Black and brown communities live in areas with much higher rates of asthma, which much higher rates of cancer. If you think of Cancer Alley in Louisiana, or respiratory problems in a lot of urban cores, those things are often separated from health equity, but they shouldn't be. They need to be tied. That if you live in an area where pollution, where lack of food, or lack of clean water, where poor sewage impacts your health, we've got to look at that as a health issue, a health equity issue, not just do you have access to hospital care, do you have access to a primary care physician, which obviously is still important, but we have to once again look at healthcare holistically, and that was what the original health centers wanted to do, is say, we can't just, once again, you're not just treating the person, you're treating the community. And if the community's problems deal with poverty, if they deal with the lack of access to good food, if they're living in places where the environment is harming their health, they've got to be community actions, not just individual actions. So those things, I think, have been consistent over the 60 years. And I think sometimes I say, when I talk to people and they're talking about things they're doing today, I'm like, that's what they were trying to do 60 years ago. I think, it's what's old is new again, Yeah, I mean, COVID's a great example where your zip code determined how the chance of you living or dying. And not just your city zip code. I mean, within a city. I mean, I live right by New York City, and, you go north of 125th Street, the rates went way up, right? You're still on Manhattan Island, but you go and you cross into a new neighborhood, and it changes because of multifamily living, because of people that could not work virtually, that had to be out, because of all because of nutrition, because of all these other aspects, and so COVID-19 is a great example of the disparities in health equity. Beyond, can you get vaccinated? All these, consider all these other factors that dealt with morbidity and mortality.
Yeah. The one thing, though, that I'll say that for me is sort of a shining beacon in what sometimes can feel really overwhelming and frustrating is that I think health centers continue to be a solution and a trusted resource and address those health disparities, address health equity, for all the reasons that we've been talking about, between engaging the community, but also just, I think, being understood and trusted. But one of the...
I just want to give you one little vignette about that, because it's one of my favorite stories about one of my favorite people. Bob Smith, who was one of the founders of the Medical Committee for Human Rights. He was one of the founders of I mentioned even the Millston Clinic of the center, and is still practicing today in his late 80s in Jackson, Mississippi. During the COVID-19 pandemic, there were billboards and yard signs with Dr. Bob's face on them, telling people to get vaccinated, because he was one they would trust.
Yeah.
Because he was the community for that long, and so that's how that change came about, and how that care came about, because you're not, those are people in the community. They're not going to trust the newspaper. They're not going to trust the TV. But they're going to trust Dr. Bob. And so that's that importance of having someone that is so tied and so trusted. So I didn't mean to interrupt, but I think that's kind of an important vignette when we tie the past to the present, and also the importance of having these dedicated physicians and nurses that are known by their communities, and the community health centers promote that.
No, I appreciate you sharing this story, and it's taking me on my own tangent, or not tangent, but I think one piece that we haven't really talked a lot about, but I think is so important and different with health centers is the healthcare workforce. I think, particularly in today's reality, you can work, health center staff can work anywhere. They could get a job somewhere else, and they're choosing to work there most of the time because of the mission, because of, the incredible success and health outcomes, and, just all of it, the mission. But I think it's really interesting because I think health center providers, one, to your point, that's amazing story, and one that I hear a version of it in so many different, every corner of the country, honestly, when it comes to health centers. But then other things like, the retention, the stay of health center providers, where, talk about generational connection, where they started with the person that is now maybe the grandparent. They saw, the now parent, and now they're seeing, the grandchild or the next generation. So you're talking 3 different generations in their patient base for the duration of the time that they've been working there. And, many of them want to continue, Dr. Smith, like you said, Dr. Bob, he probably is very deserving of retirement and a break. But, at the same time, there's that, it's bittersweet because you don't want to lose that person, that provider in the community. But I find that in so many different health centers in every corner of the country, like I said. Well, maybe 1 or 2 more questions for you. I am a lover of history myself, but I also think history is such an incredible guide for what we can learn from, but also how to prepare and anticipate for the future. So with that in mind, are there any lessons from the past that you feel should inform today's debate around the future of the health center program?
Well, and I think it gets back to what I kind of alluded to earlier, that health center leaders especially, need to be nimble. And they need to, once again, we talked about the top down and the bottom up. And one of the lessons that I always think from the history of the health center movement is that when the leaders listen to the needs of the public, that's where they have the best outcomes. And you had talked about it earlier, no matter how well intentioned you are sitting in an office in Washington, unless you see what the needs of the people in that area, because they're not the same everywhere. You can't just, as you know, and we've talked about, it can't just be, this is a good program for all community health centers. It's got to be tailored to what the local community needs. So I think being nimble and being creative is probably the best lesson from the success of the health center programs over the last 60 years.
I love that. And that's something that I absolutely agree. I think being nimble, being creative, agility, and I think maintaining a bigger vision, I think I can't say for sure, but certainly my impression in all the years of talking with health center leaders, like I said, who were sort of there from the beginning, and Dr. Geiger, there was a bigger vision and a larger commitment. And I think it's hard to keep that sort of as your North Star when you're going through massive change and sometimes challenge. But I think keeping that as the North Star and sort of continuing to guide everything through that, I think is another one. But all right, Tom, last question for you.
Okay.
I'm going to take it back to policy because that's what I do.
Okay.
So what do you think policymakers most often misunderstand about the role that health centers play in underserved communities?
Well, once again, I'll kind of refer to something we talked about before, the idea that they're just providing individual care to people, that health centers are bigger than just providing clinic care, as we talked about at the very beginning. And then the other issue is something we talked about before, the importance to the whole community, not just in delivering care, but we talked about the economic aspect. But I think there's also the empowerment of the community is very important. And especially in some of the impoverished areas where we have some community health centers, we have many community health centers. The fact that they are the boards represent that community, they give them a voice, often given people that don't have a lot of voice in a lot of areas, certainly a lot of policy areas, gives them an impact, I think is really important. And from the policy maker perspective, I think to understand why that's so valuable and why this model works so well.
Yeah, well said. I think what I would add is that the investment in health centers is the most sound investment that can be made in literally every measure, whether it be literal return, dollars coming back in and savings to the system, what it produces in the community, whether as an employer or goods and services, you name it, but then, improved health outcomes, management of chronic disease, the approach that's being taken, primary care, which we know, every dollar that can be invested in primary care is going to save you dollars down the way. And health centers are really the best equipped to do that. So we have a lot of work to do, but I'm also really grateful because we stand on the shoulders of giants, as some have said, in the 60 years that health centers have been doing this incredible work. And I will just say again, I really appreciate the incredible work that you've done, your research and your writing, telling this story. It's so incredibly important, and one that I hope more people will learn and get to know. But thank you for everything that you're doing and for joining us today. And I have a feeling we'll bring you back, Tom, because I know you're continuing to do great work. So we'll want to talk about the next discussion around your research and continued writing. But thank you so much for your time today.
Great. Thank you, Amanda, and I'd love to come back if you'd have me. So
Absolutely.
It was wonderful.
All right. Thank you.
All right.
Dr. Ward, thank you so much for joining us and helping us reflect on the history of the community health center movement. As we mark 60 years since the founding of the first community health centers, it's clear that this model was never just about building clinics. From the beginning, it was about something bigger, empowering communities, addressing the conditions that shape health, and ensuring that people who are too often left out of the healthcare system have a voice in the decisions that affect them. The principles that guided the movement in 1965 remain just as relevant today as policymakers debate the future of funding, workforce, and access to healthcare. And perhaps one of the most important lessons from this history is that community health centers have endured because they are rooted in the communities they serve. They're not just a part of the healthcare system, they're a part of the social fabric of communities across this country. So thank you again, Dr. Ward, for helping us look back at where this movement began and for reminding us why protecting and strengthening it remains so important today. And thanks to all of you for listening to Community Health Centers Unfiltered. If you enjoyed the conversation, be sure to subscribe and share the episode with your colleagues. We look forward to hearing from you in the future, and see you next time.